Good afternoon, everyone. Welcome to our webinar titled Design Principles in Decision Making that Transcend Public Health Issues. My name is Matthew Jordan. I'm one of the executive creative directors at a company called Artefact. We're based up in Seattle. This webinar is part of our Impact by Design series. So if you're interested in attending more events, either virtually like this one or someday in the future virtually or in person, please go ahead and sign up at the link that's in the chat box below. So Artefact is a strategy and design firm, and we help companies plan for the future and then also to develop the products and experiences that help them get there. We do this through a lens of what we call responsible design, which means that we're not just designing for a user, rather we're designing for positive impact across the stakeholder structure, the stakeholder landscape, across society as a whole, and even for our planet itself, for the world in which we live. So I want to introduce my sort of co-conversationalist here, Karen. And if Karen, you could just give a little discussion or a little overview of sort of you and your background, and then we can sort of get into what we're going to cover in this webinar.
Hi, everybody. Good afternoon. My name is Karen Wernli, and I'm an associate investigator at Kaiser Permanente, Washington Health Research Institute. I'm a cancer epidemiologist and a health services researcher, and most of my research focuses in cancer screening, so in the uptake of screening, and then also in survivorship care. And I've done a body of work that's in breast imaging, which is related to the topic we're talking about today.
Great, thanks, Karen. So the reason that we're here today for everyone is basically what Karen and I would like to do is to share our experience collaborating on SIMBA, which is the offering that Karen will talk about in more detail. But the reason that we want to share our experience collaborating on SIMBA is so that hopefully others would be able to leverage our learnings from this work and to bring it into the things that they're working on as well. So that's sort of the first reason that we're here. The second reason that we're here, though, is to learn from you all in the audience to get a little bit more of an understanding or to continue to advance how different disciplines collaborate and interact together on things like the SIMBA product itself. So we're all sort of in this together from across different disciplines, trying to design better healthcare experiences and better healthcare outcomes. And part of that is just sort of a good discussion in the industry about sort of how people are approaching those goals together. So those are sort of the main two things that we're trying to accomplish, the main reasons why we're here today doing this webinar. The way that we're going to structure our time together is first Karen's going to talk a little bit about the SIMBA offering itself, sort of the background and some of the key elements of it and how it was developed. Then Karen's going to talk about some guiding principles that sort of led the design and development of the collaboration on SIMBA between Karen and Artefact when we worked on the product a few years ago. And as Karen is talking about some of those guiding design principles, I'll be reflecting on some of the tensions that might be encountered as we think of an industry and how to take some of those key learnings and basically extend them out there or outwards or bring them to scale. At the end, we hope to save about 10 minutes or so for dialogue. So we'd like to, again, after we present our material, just to have a nice chat and some additional questions from you all in the audience. So as we're going through and talking about SIMBA, please feel free to add questions in the Q&A box, which is a feature of Zoom. And we'll be sort of monitoring that as we're talking and also sort of either interjecting your questions as we go or saving a lot to have a nice discussion at the end. So before we get to SIMBA, just a little bit of a perspective. So our collaboration on SIMBA was at this intersection of design and healthcare and technology. And as we all know, technology evolves really, really fast. And when applied to healthcare, which tends to move slower, but maybe with more weight, technology can often force us to ask a new type of question, really, really important types of questions like, does this intervention create inequality? Or does this product create more waste than it should? Or even does this technology take away somebody's sort of basic human rights to things like privacy, or agency or dignity. So those are some of the big questions that we ask when we think about applying technology in the healthcare space. Similarly, when you're thinking about taking lessons that are learned from something like the SIMBA project and trying to get them to scale elsewhere, basically the topic of our talk, it's also important to ask similar, very, very deep questions to make sure that in that process of scaling, we're not creating any unintended consequences or any negative impact in the world. So one thing to note when we talk about scale, scale is not necessarily just getting to more users. Scale can also be taking some of these learnings or these technologies and applying them to new disease areas, for example, that need to be addressed, or even a different type of decision that needs to be made. So SIMBA is a decision assessment tool. There's lots of decisions actually that are made in the world regarding how we think about and manage our health. So SIMBA is this decision aid for breast cancer assessment. But you can also see parallels in a decision that someone might make around breast cancer assessment to a person's decision as to whether they'd pursue kidney dialysis at home or in a clinic. So there are these very sort of big macro decisions that need to be made. There's also a whole set of very smaller decisions that patients make every day as well, even especially in the time between major medical events or time in the clinic. And we believe, or our perspective is that when you're applying these different types of technologies, or you're applying these new learnings elsewhere in new areas, design is actually what can help ensure that we are creating positive health outcomes and also positive health experiences, again, without creating any of the negative unintended consequences that is at risk when you think about moving things to scale or applying new technology or new learnings in different ways. So just a little bit of sort of about our perspective. Now what I want to do though is go ahead and sort of queue up Karen so she can talk a little bit about SIMBA.
Thanks so much for the introduction, Matthew. I have to say, in getting started, that working with Artefact as a researcher was one of the most fun collaborations I've ever participated in. And so I'm excited to share just a little bit about the work that we did.
Great.
Just to orient us all to the problem statement, the research that I was working on comes from the type of breast imaging that women receive after they've been treated for breast cancer. And so many national organizations recommend women who've survived breast cancer receive annual mammography to find second breast cancers, either a recurrence of their cancer or a second primary. Unfortunately, mammograms in women with prior breast cancer are just not as accurate as they are in women who've not developed breast cancer. And so because of this inaccuracy, some women, it's possible it's happening because of clinical factors of her first cancer, maybe because of her age at diagnosis or her treatment choices or her family history, they might be receiving either more frequent breast imaging, like additional mammograms, or also additional imaging with breast MRI. And so the research project that I was leading when I was collaborating with Artefact was to compare the effectiveness of these two imaging tests, breast MRI and mammography, using data from a large national research study. But there was this lingering question that sort of remained, which was how to support women in making this clinical decision about the use of breast MRI, and how might a decision aid sort of facilitate that decision or, as to which imaging test. I think that conceptually, you can imagine that decision aids are helpful to patients and are these educational tools that support patients when there are multiple options exist. Matthew gave several examples to set us up. And I sort of see the decision aids help patients to understand both the medical language and the culture that's needed to fully participate in these discussions with their physicians. Do you want to go to the next slide, Matthew? I think this just shows all the layout and the content from the decision aid that Artefact developed for our SIMBA tool. And then when we go to the next few slides, we'll talk through 4 of these key principles that were incorporated into that decision tool. And the first one is around personalization for women. I think that often in clinical care, patients want to be recognized and heard for who they are as individuals. And so by having them provide some relevant information about themselves, this information can help drive the clinical discussion and the decisions that they make with their clinician. And so a key feature of this SIMBA tool was to allow women to self-report information about her breast cancer diagnosis and treatment, and that the results that she would be presented with would be tailored to the data that mattered to her. Matthew, do you want to talk about the tensions?
So as sort of Karen mentioned, that SIMBA is using that self-reported data for that more personalized experience in this sort of key decision moment, often in a collaboration with a clinician. When you think about that guiding principle of personalization, but you apply it to other conditions or other scenarios, maybe where there may not be an in-person advocate or an in-person support system there, it may create a new sort of set of tensions that need to be resolved. So for example, you can think about the tension between sort of the benefit of sharing your data to create a more meaningful experience for you and yourself, maybe a more informative or more insightful experience. But there's also on the other side this risk, again, if you're not in the support infrastructure of a clinical setting, there's also just the risk of data being misused. If your data unsure where it goes, or it might not be known as to how it's going to be used, there's just this like potential tension that can be created. So some of the things that we ask about in thinking about personalization in the different situations in the healthcare setting is, how can we actually help people weigh the benefits and the risks of them sharing their data for personalization, especially when it might not be a situation like in SIMBA, where there is somebody there sort of across from you or sort of guiding you through the process. So these are sort of the kinds of questions that we ask when we think about translating things from SIMBA, where the personalization element or feature is very, very important and critical, thinking about how that may show up in the world and what are some potential negative impacts of following that kind of a design principle. Karen, do you have anything to add on this one, or would you want to move on?
I think just the one thing to add is, in thinking about how we share data, there are federal and statewide compliance guidance that often, especially in healthcare settings, guide how we protect data and how information that's provided either through electronic health record or through patient-reported outcomes are secure, confidential, and even anonymous. So
Yeah, great.
to keep those compliance guidelines in mind.
Awesome. Want to talk about the next principle?
Yeah, so the next principle was about accessible information. And this was really important to us in that we wanted to make sure that the content was presented in a way that a lay audience would understand, and specifically that it would address the range of literacy and numeracy needs. We did use these international standards for decision aids in order to make sure we met quality metrics that have already been established for decision aids, but also paid special attention to how the information was presented such that the vast majority of women would be able to understand the content that was presented to support their conversations.
Great. So I'm thinking about this one. Obviously, the goal or the principle of literacy and numeracy needs and addressing them through more accessible information is great, and it's a core element of what SIMBA offers, especially because it provides that access to the broadest range of people possible. Sort of the access that we're providing in that sense is information, and there's, as Karen mentioned, there's very clear standards for how that information should be presented and sort of how to present that clearly. But when you think about something like access at a much higher level, if you think about sort of literal access to things, to different types of resources, whether it's information or supplies or interventions or even just basic expertise, then things become a little bit less clear in terms of making sure that we have the right type of access for everybody. So there is this tension between sort of what is the possible immediate positive impact that we can have by delivering resources to those who are sort of more accessible or sort of immediately in front of us, versus the time and the effort that might need to be invested to get resources to those people who might be in a less accessible situation, but may be equally in need. So one of the things we think about is just how can you understand the possible inequities that are created in some of these different interventions as we're thinking about them and designing for them.
I think that's a really important point, in part because as a result of COVID, so much of the care delivery is moved to virtual care. And I think that that can be particularly beneficial to communities that have had challenges in coming into clinic, particularly people who live in rural settings, and our availability to offer online or web-based technology might actually be a great benefit for them, but we still could be disservicing others, especially in a virtual care environment, if they don't have secure access to the internet or reliable access.
That's right. So again, in that situation, there's been a slight shift in terms of the inequality. So the access is now more in terms of literal internet access, whereas before
Yeah,
it might have been more about physical access. So again, just thinking about things in these different types of tensions is a good way of making sure that we are trying to stay true to our goal in the industry, which is better health outcomes and also better healthcare experiences for all people. We can move on to the next guiding principle for SIMBA.
the next guiding principle was on data-driven visualizations. And as a researcher, this was a really important thing for me. This was intended to show the sort of the results from my own research program as to what outcomes women might expect if they received a mammogram or if they received a breast MRI. So the quality and the integrity of data, I think, are integral to the success of such a tool. We're trying to develop these data visuals to display what we think are the important patient-centered outcomes that we had identified in our research. And we gather these data, and these results come from decades of publicly funded research of breast imaging in the United States. So it's a reliable data source. It's something that's been around and collected for many years. And it's a trusted data source that's influential to the public. And the presentation of these data was also made such that it wasn't intended to present a biased perspective in any way. It was supposed to be sort of balanced in how it shared the results.
So in this situation, this is one of one of the guiding principles that I find most fascinating, especially when I think about some of the other work that we do at Artefact. So SIMBA was targeting this sort of single but very critical sort of macro decision that a woman may need to make about breast cancer assessment. There's other conditions in the world that we've actually designed for at Artefact that are more about many but smaller or micro decisions in terms of how people are taking care of their health. So you can think about things for people who live with type 1 diabetes, for example, and the hundreds or thousands of decisions that they may need to make in the course of a day to stay healthy and to pursue the best health outcomes. You can also think about people who live with Parkinson's and how they have to balance sort of meal times with taking their medication as well to make sure that they don't sort of have more side effects than they want to. And those are decisions that are made, again, not in sort of these big healthcare moments, but in sort of the flow of everyday life. And a lot of these decisions are actually supported or increasingly supported through MMAs or mobile medical apps. And again, these sort of additive decisions that these people may be making, these micro decisions, actually sort of ladder up to an overall potential health outcome and health experience. So when you're thinking about like scaling types of decisions from sort of bigger decisions like in SIMBA to more sort of smaller micro ones that are happening throughout the course of a day, you have to think about that tension that that Karen brought up, this sort of the trusted source and the rigor that's there. That brings the information that can support sort of a micro decision, again, founded in years of research and understanding, versus sort of if someone's making a micro decision, what is sort of the reliability and the timeliness of that contextual data that they might need, again, in that moment to make that very, very specific dosing or lifestyle decision. So this is one that I think is creating a lot of interesting tension, specifically because the work that we do is not just sort of on things like the decision aid with our work with Karen, but also on the sort of MMA side, the mobile medical app side as well. Karen, do you have any thoughts on this one?
I think not. In interest of time, maybe we should move to the next one.
Perfect, let's do it.
So the last value we wanted to bring up was this value reflection. And in the SIMBA decision tool, women were able to prioritize the topics that are of greatest interest to her to help facilitate this conversation with her clinician. And I think that the values reflection builds on the personalization component that we mentioned first as being a key principal design element. But also, it doesn't assume that all women with the same measured attributes would make the same decision, or nor that each of these conversations would be the same. You know, it sort of blends this personalization and value into how those conversations get crafted.
Great. And again, thinking about how might this sort of scale outward, if you think about things, this idea of value reflection, but what you're applying it to is not just sort of an individual their decision, and how do you sort of support that individual and align to their values and their identity and their sort of cultural context. But if you're thinking about something much broader, where sort of population behavior change is the goal, if you think about things like social distancing or hand washing or vaccinations even, that's when you start to get into tensions like, how do you weigh the support of an individual with the overall benefit of a community when the goal is of that community to act as one uniformly and sort of perpetually over time, because that's when you actually can drive towards better healthcare outcomes. So some of the things we think about here is just what's balancing, or how do you balance what's best for the individual versus what's best for the population at large, in the context of still supporting some of the individual decisions that people want to make. So those are sort of the big guiding principles that that was used in SIMBA, and also our thoughts on how they may or may not scale and what some of the tensions are. Recall we had sort of personalization, we had accessible information, we had data-driven visualizations, and we had sort of value reflection as the main sort of overarching goals, overarching guiding principles for our work in SIMBA. But now I think what we'd like to do, again, in the essence of time, is to just sort of open things up and to see if people have questions that they would like to ask. So while I pull those up, Karen, do you want to give just a really quick update on sort of what's happening with SIMBA now while I pull in some questions?
Yeah, the research comparing the effectiveness of breast MRI and mammography was published last year in Radiology. And what we found was that breast MRI leads to improved cancer detection, but at the cost of more false positive biopsies. So women are going through a lot more biopsies in order to find that cancer. And it's not clear that if she had waited until the next mammogram, that it might have, been caught then. And so it's not clear that the MRI leads to improved outcomes overall.
Okay. Okay, so we have a question from the audience, and this is from Felix, and it says, just given the flood of information in our current health pandemic, and also the age, also sort of existing in this age of misinformation, what can, one, researchers presenting data do to ensure that it's perceived as credible? And two, what can the public do to verify the credibility of the data that's guiding their behaviors? So Karen, do you have any thoughts on this one? It's a great question, and I love that it sort of highlights both from the researcher side and also from the public side. Do you have any thoughts on this one, or?
Yeah, I think this is a really tough question, in part because across the country, people are gathering information from different sources, and how they test or check their own assumptions about whether or not the information is credible is variable. I can say that in this current health pandemic, one of the leaders, or there've been a few, but like Johns Hopkins has a lot of data gathering that they've been doing and have been publishing. And when you look at other sites that are putting out data information, they're often citing back the Johns Hopkins site. And so I think that when you are looking at these sources, sort of trying to figure out where they're getting that information from and whether or not that information comes from a reputable source. A lot of information is also being generated from the Centers for Disease Control or from state health departments. And those in and of themselves as government agencies should lend to their credibility.
Awesome, great. If anyone else has any other questions, please feel free to add them to the question and answer feature in Zoom. Otherwise, I have another question. for Karen, which is, again, building off of just the globally shared experience that we have with COVID. How is that impacting the work that you do in terms of clinical research? Has that just sort of, have you been able to carry on in your work, or has it been just sort of as disruptive as we've heard it's been in other, like definitely frontline healthcare workers in other industries, absolutely. But how about on just sort of the clinical research side? Have you also had a similar experience?
Yeah, it's been incredibly disruptive to
Okay.
clinical research, in part because as we try and protect patient safety, a lot of the routine things that we're doing in clinical care sort of ceased or stopped as
Okay.
being non-essential services.
Got it.
And I think that while we initially thought it was going to be something that was like a dramatic reduction in services with some sort of ramp up, you now realize that we're in this long recovery, and our return to normal will never really look exactly like it did before.
Got it. Got it. So we have a question from, I think, Vineet, and I think it's for you, Karen, and I can have some thoughts as well. But how do you see the tensions between human interaction in care delivery versus delivery through digital tools? So it might be a good question to sort of talk a little bit more about SIMBA again, and sort of how you were thinking about that as a decision tool being used sort of by the patient on her own, or sort of in as sort of also a discussion guide, not just a decision tool, sort of with a clinician in the healthcare delivery setting. Do you have thoughts on that?
A few. I think one of the things that came up a lot as we were developing the decision, the SIMBA tool, and the patient advisory board that I had for my research project contributed to some of the user testing, is that all the women said that they wanted to use that in concert with clinical care discussion.
Got it.
What I hope is about to happen, though, is that often the way that those work now or pre-COVID is that you might see your doctor, they might give you some information or talk about a care decision and give you information to go home with. And it sort of happens opposite of what you'd like to see. What you'd like to see is this anticipation of the conversation, some material provided to the patient, for them to be able to read it and educate themselves and then come together for the discussion. And so it's possible if we do move and retain these virtual health care appointments, that it might actually facilitate the sequence of those events better.
Okay, great, awesome. And from your perspective, is that how would you just sort of approach that from a research perspective? Is that just, I mean, I think it's sort of like a more from a research methods perspective. Are there ways that you would investigate sort of, is that true, or how to test out that hypothesis? Do you have any thoughts on that?
I think I'm not sure yet. I think
Okay.
because of this huge disruption, you're like, oh my God, that seems like a really interesting question, but something we can't really ask for 2 years.
Got it. Got it. Thanks. Great. Great. Okay, let me see. Another question from Sarah Brush, and this is for Karen. So as an epidemiologist, how has collaborating with folks in design influenced your approach to research? How do you see this type of collaboration bringing value in the context of COVID, for example?
I think because of the nature of how research grants are structured, we're often operating on these shoestring budgets, and we sometimes promise to develop a decision aid or some sort of product or tool that really is out of the scope or out of the range of the work that as researchers we're able to accomplish. And so being able to work with Artefact just elevated my expectations as to the types of products we could actually generate from research. I found it to be astounding, and is something I'm trying to bring into all my research as I move forward, even if it's not a specific decision tool that's being developed.
Awesome. I know that
Did you see
Artefact.
that?
I'm sorry,
Oh, go ahead.
I was just going to say that Artefact really, really appreciated the collaboration with you as well, in terms of being able to work so deeply on the clinical research side as well, as something that we're not always afforded the opportunity to. So we really appreciated it as well.
Do you see the question from Emma?
No, sorry.
Well, I'll read it then because
Please
I
go
can
for
see
it.
it. There's a question from Emma, and I think it sort of is a good segue to your last comment. With
Okay.
healthcare varying across the country and the world, how do you structure your approach to research and design to take into account a holistic view of patients? And I would say that the initial work that was funded for the SIMBA project was from the Patient-Centered Outcomes Research Institute that required collaboration with patients and other stakeholders. And it's a format that I've adopted actually through all my federal research grants, is to continue to involve patients. And with that, there's often some sort of qualitative component to understand what's most important to them, um, to understand how clinical decisions and other issues might impact them. Um, and so I try to incorporate those perspectives in how I design the research, the questions that we answer, and the big questions we're trying to find the solutions for.
Awesome. I think we're out of time. I think we're supposed to wrap at 12:30. Is that correct, Karen? Sorry, I should know this. This is like the
Yeah,
last
I think
question that
that's
I have.
true.
Okay. Perfect. Well, I just want to say thank you to you, Karen, for taking the time to share some of your experience on the amazing work that you do in SIMBA and sort of the guiding principles, and also just taking the time to sort of reflect on them and how they sort of may or may not scale to other situations in healthcare. And I also just want to say thank you very much for everyone who was able to attend. We really appreciate it, and hopefully you were able to learn something and sort of think a little bit more about how you could bring things like decision making tools and also guiding principles into the work that you're doing as well.
Thank you so much.
All right, sounds good. Thank you, everyone.
Take care.
Bye.